Hello, my name is Dr. Azimra Thor, a PGY1 at the University of Florida College of Medicine in Jacksonville, Florida. Today I'd like to present an interesting case that we saw at our university. The title of this presentation is A Rare Cause of Myopericarditis with Cardiac Tamponade due to Arcobacter in the setting of COVID-19. Our case begins with a 32-year-old male with a history of HIV and AIDS and ESRD that presented to the ER with shortness of breath, fever, and pleuritic chest pain for 1 day. 7 days ago, he reported loss of taste and smell, diarrhea, and a negative COVID-19 test. Shortly afterwards, he said he received the first dose of the Moderna vaccine. In the ED, a repeat COVID test screen was performed, and it came back positive. An ECG also showed diffuse ST elevations, PR elevation in AVR, and PR depressions. These constellations of findings were indicative of a pericarditis-like picture. The EKG in question is here presented in the middle. Physical examination was remarkable only for a pericardial rub with normal JVP. The rest of his physical exam was unremarkable. Laboratory studies showed mildly elevated high sensitivity cardiac troponin T of 103. Additionally, an elevated high sensitivity CRP of 344 was also noted. This result prompted a transthoracic echocardiogram that showed a large circumferential pericardial effusion characterized by an inflammatory fibrinous deposition. The largest pocket of fluid was noted around the left ventricle, measuring about 30 centimeters, with parts of the heart demonstrating tamponade physiology, including diastolic collapse of the right ventricle. Of note, the patient was never in hemodynamic instability. An urgent pericardiocentesis was performed, and about 2,000 cc's of fibrinous fluid was drained. During his hospital course, the patient had blood cultures and pericardial fluid cultures which speciated for Arcobacter, a Campylobacter-like organism. The patient was treated with high-dose aspirin and colchicine along with the antibiotic ciprofloxacin and was discharged home with follow-up soon after. The TTE in question is shown in the middle as well. As for our discussion, bacterial infections are a rare cause of pericarditis and represent less than 1% of all cases, with most having an idiopathic etiology. The most frequently reported bugs include Staphylococcus, Streptococcus, Haemophilus, and Mycobacterium tuberculosis. Bacterial pericarditis is often precipitated by infection spreading from the lung or pleura, directly via the mediastinum, or less commonly by hematogenous spread. There are no reported cases of bacterial pericarditis caused by Arcobacter. As we've said, it's part of the same family as Campylobacter, and these gram-negative rods are often linked to enteritis and occasionally cause bacteremia. Risk factors for acquiring a Campylobacter infection are immunosuppression, alcohol abuse, liver disease, pregnancy, medical devices, and old age. For our patient, he was immunocompromised due to his previously mentioned comorbidities and his recent COVID-19 infection. We hypothesize that the Moderna vaccine may also have contributed due to its observed risk of developing myocarditis as a well-known side effect. Clinical presentations of bacterial pericarditis are usually subtle and can be fatal due to the rapid accumulation of pericardial effusion, leading to cardiac tamponade if not diagnosed promptly. Clinicians ought to maintain a high degree of suspicion in the immunocompromised host. Our case highlights the need for early recognition of bacterial pericarditis. Thank you.